So welcome everyone. Today at Choose Sleep, we are going to talk about artificial intelligence in sleep medicine, what the sleep fellow needs to know. My name is Anuja Bangyapadhyay. I'm one of the pediatric pulmonologist and sleep physician at Indiana University School of Medicine. And I am the current chair of the Artificial Intelligence in Sleep Medicine Committee. Today, I have with me Dr. Sun, who is an instructor at Massachusetts General Hospital and Harvard Medical School at Boston. He did his postdoc with a focus on AI applications in sleep medicine to extract brain health from sleep signals. He serves 2 years in the AI and Sleep Medicine Committee in AASM, and he also received the Outstanding Early Investigator Award from the Sleep Research Society in 2020. So moving on, I have no conflict of interest to disclose, and neither does Dr. Sun. Few housekeeping rules. So questions can be entered in the chat feature anytime during the presentation. Questions will be answered at the end of the presentation. Between Dr. Sun and me, we will try to do some on the go if we can see any questions come up. This webinar is being recorded and will be posted on the AASM website about 2 to 3 weeks after the presentation date. So the learning objectives of our talk today would be to familiarize all of us with scope of AI and the basic steps in machine learning and deep learning. We hope you will understand why sleep medicine is uniquely positioned to leverage AI. We hope you will be able to name a few applications of AI in sleep medicine. And we hope that you will be able to name a few applications of AI in sleep medicine using wearable devices. So 16 years ago, popular sitcom The Jetsons had shown a novel futuristic way of seeing patients. Now cut to 2021, telehealth or virtual video visits have become the new normal. What seemed novel and almost impossible 60 years ago is today's reality. All of this has been made possible by technological advancements. Artificial intelligence is one of the biggest contributors to this advancement. But before we go any further, let's take a step back to understand what exactly do we mean by artificial intelligence. I'd like to ask Dr. Sun, who can help us demystify the commonly used terms in AI.
Thanks, Dr. Bangyapadhyay, for the introduction. Many people have heard about artificial intelligence or AI, but what is it exactly? In general, as this picture indicates, AI is a broad field which contains machine learning, and then machine learning contains deep learning. Yeah, let's look inside each term. Next, please. So what is AI? Here, AI is the broad science of having machines to complete human tasks. It basically includes at least 4 domains, including learning, planning and motion, reasoning, and general intelligence. I would like to provide a few more details in each of the domains. So learning, what does learning mean? It means learning to classify, for example, whether it's a cat or dog, learning to predict whether it will rain tomorrow, or learning to find some phenotypes, for example, obstructive sleep apnea with resistant hypertension. The second is planning and motion. So the AI can plan optimally and act optimally to optimize some future outcome, such as some adaptive strategy to improve the CPAP adherence. And third is reasoning. For example, why this patient will have bad outcome. Is it due to hypertension? Is it due to other comorbidities? And the last one is general intelligence. That means a machine can solve a wide range of problems and may even pass Turing test to replace a doctor. Next, please. Yes, so machine learning algorithms, which is a subset of artificial intelligence, learn from data with human-specified features without explicitly programmed commands, and improve performance with experience. Let's look at a few steps of machine learning. So let's say you want to identify whether this 1 second of sleep EEG signal contain a spindle. Then you would like to characterize its frequency, its shape, its duration, and its baseline amplitude, etc. All of these we call features. And now you want a method that can combine these different features and tells you whether it's a spindle or not, or how likely it is a spindle. So this is a very specific example of machine learning. So, and if during the training, you tell the machine the true answer, it is called supervised learning. And next slide, please. Yes, so then the previous slide is about machine learning, and now a subset of that, deep learning, it's a type of algorithms where themselves can learn the important features in the data. So you may have noticed that in the previous slide, defining those features require human knowledge. And deep learning takes one more step forward by removing this need for human knowledge. So they have additional layers or steps to first learn these important features from the raw data, and then apply the same machinery to the learned features. So the fact that they need additional layers to learn the feature is the reason why they are called deep learning. Here is another example to better understand this. Suppose you are a freshman with no knowledge at all in sleep medicine or even signal processing. And then you're asked to look at this image, this signal, and you will find, okay, sometimes the signal go crazy, sometimes the signal fluctuates slower or faster for a few seconds. And you will use these patterns to try to answer if it is a spindle or not. Yes, that's exactly what deep learning does. Deep learning may find either patterns that we human understand or we human don't understand, but deep learning will find these patterns and then combine them and provide an answer. Next slide, please. Yes. So now that we talked about deep learning, let's take a deep algorithms, which is neural network. So this slide shows an example, a very simple, it's called feed-forward multi-layer neural network, which is a basic form of neural network. As the color indicates that it has multiple layers, and the first layer, the yellow color, is the input layer. The middle layers, the green ones, they are hidden layer. And the last layer, the red one, is the output layer. So in most cases, each node is identical to each other, and each node receives input from the previous layer, and then do a weighted sum over the inputs, and then apply a nonlinear transformation, and then output to the next layer. So actually, from this figure, you can see that each node in the next layer is connected to all the nodes in the previous layer. So this is called full connection. And each connection has a tunable parameter or weight. So when people say, I'm training a neural network, that actually means to tune those parameters, tune those connections, so that the output matches our desired output as much as possible. The difference between the output from the neural network and our desired output is called a loss. So actually, we can minimize. So in this example we just mentioned, we can the loss is the difference between the neural network output and the desired output. But in modern deep learning, we have much more diversity and flexibility in designing a loss. So here is just a very simple example. Next slide, please. Yes. So as you can see from the previous slide, the connection between the layers, it's full connection. So that will lead to many tunable parameters, which needs much more data to train. So it's not very efficient. Then convolutional neural network, or CNN, was used to address this problem. As you can see from this animation, it tells you how convolution is done. So basically, you have a receptive field or kernel. For example, this shaded area in the blue previous layer, you use this kernel to scan the input, where the input being the previous layer. And each output in the next layer is a weighted combination of the inputs within that kernel, within that shaded area. So all the parameters in those kernel share the same parameter. For example, in this figure, the kernel is 3 by 3. Therefore, there are 9 numbers representing this kernel. And these same 9 numbers, they are shared across the whole input. That's why it saves the number of tunable parameters a lot. Next slide, please. Yeah, so now we have a general understanding about convolutional neural network. So after all these models, how do we train a machine learning or deep learning model? So once we have a suitable model in mind, here are some steps to train a model. At the beginning, we need to pre-process the data set. So for deep learning, as you might heard, that the input can be raw, but there's some flexibility. For example, in sleep medicine, you still want to filter out the 60 Hertz line frequency or other frequencies depending on which country is the signal collected. And then we still want to do bandpass filtering, for example, 0.3 to 35 Hertz to limit your signal to a meaningful range. So after this pre-processing, then we can train the model. We can input this pre-processed signal into the model. During training, we usually do something called cross-validation, which splits the whole data set into training and testing sets, where the testing set is also called held out data set. You do this in turn so that every part of the data set has the opportunity to be the held out data set, and you evaluate on the held out data set. So the purpose of doing this kind of cross-validation is to estimate the performance on held out unseen data, since we don't want our model to simply remember the answer in the training set. We want our model to perform well on unseen new data. That's the purpose. So finally, we can evaluate the performance using various metrics. And for sleep staging, for example, we usually use, for example, confusion matrix or Cohen's kappa or F1 score. Thanks. Let's go back to Dr. Bandopade.
Helpful to unmute. So now that we have a deeper understanding of AI, let's take a look around and see where is it being used. So AI is everywhere, be it your self-driving car, the facial recognition you use to unlock your phone, Google Lens to recognize images, or even typing assistants to correct your grammar. AI is everywhere. And we don't even need to look that far. If you look at modern medicine, you'll find plenty of application of AI, be it natural language processing, where you're completing patient dictations, or learning systems like Empower MD, which captures and synthesizes patient-physician conversations with subsequent production of encounter notes, or even the health data living in the cloud, or medical images turned into measurement devices, AI has found its place in modern medicine as well. The primary goal of AI is to allow physicians to spend more face-to-face time with patients and improve workflow. So how does sleep medicine benefit from AI? Sleep medicine is uniquely positioned to leverage AI in our sleep. As our sleep studies, you get 8 hours of uninterrupted physiological data. Our patients use several tracking devices, and we have access to EMR data or electronic health record data. Together, when we use all this information, it can be utilized to develop many predictive models. So this field of AI in medicine, though, is relatively young. If you look at this timeline, you will see while industrial robots became reality back in 1961, AI-assisted sleep scoring was only approved in 2017. However, since then, AI has grown by leaps and bounds in our field. One of the most common applications of AI is automated sleep study scoring. We know between humans, our overall interscorer agreement is 82.6%, as described in our ISR program. There was a meta-analysis performed a couple of years back, which showed that AI-driven PSG scoring showed overall agreement of 85%. So what are the commercially available systems that are being used? There are several which are available commercially. Some of these can utilize machine learning. Some of these can utilize deep learning. And deep learning, as you recall, works like our human brain and learns from data sets without assistance of explicit commands or rules. So talking about those data sets, what are the commonly used data sets that are being used to train our models? Some of the commonly used data sets are shown in this slide. What I want you to take home from this slide is that remember, a data set or machine algorithm is only as good as the data set which is training it. So as an example, if I have a data set which was trained on 32 to 56-year-old patients with COPD, it may not be the best suited to score studies on a 4-year-old healthy child. So this highlights the need for performance metrics to evaluate AI-assisted scoring. Dr. Sun will now go over some of the commonly used performance metrics.
Thanks, Dr. Bandyopadhyay. Before we dive into these performance metrics, I think first, suppose we are doing a classification for wake versus sleep, where each 30-second epoch could have the actual class being wake or sleep and the predicted class being wake or sleep. So altogether, when you put them together, there are 4 cases. So this is in a binary classification where you classify things into either wake or sleep. So in this binary confusion matrix, we usually define one of the classes to be positive and the other to be negative. So for example, if we say wake is positive and sleep is negative here, then we can have, for example, all these 4 numbers, including true positive, false negative, false positive, and true negative. And as you can see, the numbers around those 4 numbers, different metrics are derived and using those 4 numbers. Next slide, please. Yes, so here are some important performance metrics that are derived from the confusion matrix. So we are very familiar with accuracy, which tells you the overall agreement between the actual and the predicted sleep stages. And there's also sensitivity, which refers to the model's ability to correctly detect positive when it is indeed positive. And specificity refers to the model's ability to correctly reject positive when it is indeed negative. And then F1 score in the fourth row refers to the harmonic mean. It's kind of mean between precision and recall. So for F1 score to be high, you need your precision and your recall both to be high. And the fifth one is AUC, which is area under the ROC curve. So AUC is an integrated measure of how true positive rate and false positive rate, how does those two change with respect to different cutoff values in the prediction. Yes, and then the last one, which I think is pretty important, is the Cohen's kappa value. So Cohen's kappa measures the degree of agreement beyond chance level. So actually all measures except accuracy and Cohen's kappa, the other four, they are defined in binary classes. So if we want to apply these to our five sleep stage classification, then you need to derive these metrics for each of them and then average them. So actually, the reason I say why Cohen's kappa is quite important is that, well, first of all, it's widely used in sleep staging. And second, it considers the imbalanced chance level for each sleep stage. As you can see on the second column, last row, it incorporates the probability of chance agreement. Next slide, please. Yes, so actually, this is a very important problem, imbalanced data sets. As we know, different sleep stages consist of different percentages of all epochs in the night. For example, we know N2 is about 50%, and 1 is about 5 to 10%. So therefore, if you have a dummy model that just gets N2 all the time, then the model will be correct 50% of the time, which is higher than the hypothetical 20% chance level in a 5-class classification problem. So the imbalance property in the sleep stages must be considered in the metric when you evaluate the performance. Cohen's kappa is one of them that can handle this. Let's go back to Dr. Bandyopadhyay.
Thanks, Dr. San. So as you can see, evaluating metrics from an AI-driven algorithm has its own unique challenges. So the moral of the story is, if you are comparing two AI-driven algorithms, you have to make sure you're comparing apples to apples. An ideal method to compare these classifiers will be if they were developed using the same channels, if they were trained on the same data set, if they were validated with the same procedure. However, this may be a utopian concept, as different manufacturers have proprietary lines. And there is a critical need to increase transparency on how these algorithms are being trained. And it becomes all the more important now to regulate how these algorithms can function in medicine before these classifiers become mainstream. So why are we not using this technology? There could be a couple of reasons. It could be aversion to technology. Some providers may not want to change their mode of practice and incorporate AI. It may be that some may perceive this as not user-friendly. It may be that there are concerns that data is not securely stored. Other than the factors mentioned in the previous slide, the truth remains that we still have considerable work to be done before we can incorporate AI-assisted PSG in our workflow. The biggest challenge is accurate scoring. While AI-assisted scoring has reasonable success in sleep staging of healthy population, scoring in populations with sleep disorders is still a work in progress. While AI can easily identify normal, there is some amount of subjectivity or clinical judgment to be used when interpreting abnormals. Furthermore, in order to make the algorithm more generalizable, we need diverse training data sets to train these algorithms before we can incorporate AI in our sleep flow workflow. Now, I talked a lot about AI and automated sleep scoring, but there is also significant application of AI beyond automated sleep studies. So here, over the next few slides, I want to give some examples of how artificial intelligence has been used in area or scope beyond sleep studies or sleep scoring. So in this example, AI has found its use in diagnosis of sleep disordered breathing without using the traditional airflow channels. So over here, I have an example of a study which utilized a neural network to detect OSA based on pupil size and EEG changes. Here is another example, which used image detection of the cranial X-rays to diagnose patients with OSA using machine learning. AI has been used to screen patients for OSA based on demographics and comorbidities. So in this example, they took a couple of thousands of patients coming to a clinic, and they looked at all the different parameters, including their comorbidities, their demographics, and then they analyzed, the predictive model analyzed how many of them will have sleep apnea or not, and they corroborated that with the PSG results. And they found that it's doable, and definitely the predicted model can work. So here is another study which came out about last year. So in this study, AI model was used to estimate the contribution of the different OSA endotypes on the OSA severity, which was marked with the help of AHI, and based on just using sleep study parameters. So we know how much of that AHI of 15 per hour were due to the different OSA endotypes. Now, AI has also been used to facilitate treatment. Here is an example of a machine learning algorithm that has helped improve CPAP compliance by improving patient engagement. Now, moving beyond sleep disordered breathing, AI has found its use in other sleep disorders such as narcolepsy. Here is an example where hypnodensity features in the single night polysomnogram has been used to diagnose narcolepsy. And the results, as you can see, were found to be comparable to the traditional PSG MSLT combination that we do in our clinic. AI has found use in analyzing big data, such as this example here, where the authors looked at the European Narcolepsy Network database, and they curated the clinical features of narcolepsy type 1 and type 2. So going through the entire database would have taken months and if not years, whereas with the help of AI, any such big data analysis can be done in super quick fashion. Not just narcolepsy, AI can also help distinguish and help with insomnia. So AI in this example can help distinguish insomnia phenotype through EEG analysis. And here you can see that between the controls, paradoxical and psychophysiological insomnia, they have distinct EEG patterns, which even to the most trained eyes, I don't think we can find those patterns, but AI can. One of the strengths of machine learning is its ability to identify patterns. AI has been used to cluster insomnia patterns through data obtained from wearable devices in this example. So similar to what PAP adherence and AI has also found a role in the management of insomnia through delivery of digital behavioral intervention. So here's an example of an app where you would log in and they would ask you some screening questions. And based on that, the algorithm will recommend a form of CBTI treatment for you. and then they will deliver that digital behavioral intervention, especially during times of COVID. I think the world has taught us that we need that flexibility, and patients prefer that flexibility. So here you see such examples being used in clinical medicine. So AI can predict circadian rhythm through wearable device. This has found great use in personalized chronotherapy. So collection of individual data using wearables is first done. Then that data is analyzed in platforms with system modeling and machine learning. And finally, you come up with the chronobiological rhythm of that person. And studies have shown that when you do personalized chronotherapy, especially in using anti-cancer drugs, then you can, if you time the medicine correctly, then it works better. Now, a few more examples. AI has been used to diagnose REM behavior disorder through EEG analysis. And we know that REM behavior disorder can predict neurodegenerative disorders. So this is a growing field, and I think more studies will come up in the next couple of years. And finally, AI has also found use in diagnosis of sleep-related movement disorders. So in short, AI has found application in almost all sleep disorders. AI helps analyzing large amount of data in very short time. However, the machine can only do what it has been taught to do or what it has learned to do. The machine cannot replace our clinical judgment. Now, I'll take a pause there and then switch gears. While we have talked extensively about AI, I'd like to spend a few minutes talking about consumer sleep technology. So when I say consumer sleep technology, I'm referring to the many devices which have flooded the market, which claims to track your sleep, track your oxygen level, track your heartbeat, and so on. So briefly, we can classify them in about 3 different types of technology. You can say they are wearables, when you wear them on your wrist. You can say they are nearables, when you keep them near you at the bedside when you fall asleep. Or you can call them electronic textiles, where you embed them in your clothes. Now, keep in mind, these devices may or may not be medical grade or FDA approved, but you will still see them in the market. This is a busy table, but here are a few examples of FDA approved consumer sleep technology devices used to diagnose sleep disordered breathing. Now, the take-home message from this table, what I want to highlight is that if you look at the reported sleep metrics, you will realize that not all devices report the same metrics. You will also see that not all devices utilize the same principle, and some of them can use more than one principle. Furthermore, I think what is most unique is if you look at the validation study section, you see that not a lot of them have published validated data. Now, how do we overcome that challenge? If a patient comes to you in the clinic with this device, I think we have to first know what kind of principle it's using, what are the reported sleep metrics, and if there are any published validated data or not, because that device may not be applicable to your patient or may have been trained in a different population set. So at AASM, our Committee on Emerging Technology reviews some of these devices. I strongly encourage our fellows and members to use these reviews as resources because we have done that work for you. So this is a plug for the hashtag sleep technology, where you will find some of the reviews of these devices. So if you come across one such device, I'd highly recommend going to this resource and utilizing it. So what are the advantages of using consumer sleep technology devices? Now, these are tools to engage patient awareness and enhance patient role in their care. It's easily accessible and inexpensive, unless you're probably buying the newest generation of Apple. They have real-time feedback for consumers, so they may objectively identify sleep problems. The longitudinal data collection for the same patient is very helpful. And it can collect data offsite or remotely. And potentially, it can be integrated with electronic medical records, and some other branches of medicine have tried to do this. So, what are the disadvantages of consumer sleep technology? So, the disadvantages are almost similar. So, if your patient is using these consumer sleep technology, if it's validated, that's great. But when you get back those results, you will get like sheets and sheets of all this data. And sometimes you wouldn't know what to do with that data. So we have to come up with a way where we can synthesize all that data into what's important and what's not, and try and integrate that with electronic medical records. Only then I think this consumer sleep technology will be of value to us. So how can we utilize artificial intelligence and consumer sleep technology? So, as I said, the overwhelming amount of unvalidated data, the way we can harness that and leverage that is by using artificial intelligence to analyze this big data. But the people who are using these or making these algorithms now, they have to understand that it's a heterogeneous population, and they have to then create probably buckets or homogeneous population where they can test the validated data, where they can see how useful this is going to be. Only then I think we can reach our goal of personalized sleep medicine. So where does AI fit in today's modern medicine? AI has immense potential to become a very important tool, and it can change the face of sleep medicine. It can help collect and analyze large amount of data. Integrating that data can help us move towards precision medicine and personalized treatment. In today's day and age, when we have access to electronic medical records, we have access to omics, and we have access to like knowing about external environment. We have access to objective sleep assessment, which happens in the sleep study in the lab, or even through consumer sleep technology. And we have access to sleep metadata, where we have insurance claims, social databases. We have even social media. We have human interface. Using all of this together, AI can integrate that. And with that help of that collaboration, we will be on our path to personalized sleep medicine. However, there is still a lot of work left to be done in terms of collecting diverse data sets for greater generalizability, as well as regulating AI-assisted algorithms. So in other words, we still have miles to go before we sleep. I do see Dr. Sheligar there, and I want to give her a shout out because I think it was her idea that we talk at this platform.
And it was incredible as always. Thank you so much.
Thank you. If anyone is interested in learning more about AI and sleep medicine, we have a committee. We are very interested in educating the next generation about AI. So feel free to send me an email or anyone in our committee, Dr. Sun or me, and we will love to talk more about applications of AI or how we can help you. So just reach out.
And final question.
Well, I think we can give you 20 minutes back of your life.
Hey, let me ask, if you don't mind, it seems like there are a lot of more and more products coming on the market, but like you said, they're not validated, they're not approved, but we keep seeing more and more. Do you expect, or have you seen any shift of the products that are on the market going for approval or validation, or just expanding the selection?
So I think there has been an increased awareness that these devices need to be regulated. One of the examples would be FDA holding a transparency in AI ML learning algorithms workshop earlier last year in fall. So I think even FDA understands that just approving a device isn't really cutting it, and there needs to be some transparency associated with it. So with that in mind, the industry, now that goes back to the industry where they feel like, okay, now we have to give more information. And the more conversations we have, I think the more it will help. ASM is hosting a couple of roundtables with industry people who specialize in sleep products. And we are having this conversation with them. So I don't think there's been a rapid change, but again, I think the awareness has just started. But as physicians, I think all of us need to be aware of this. And we need to understand that all these algorithms are subject to failure or subject to make mistakes, like humans. But we definitely need to then have that supervisory role when we are utilizing these.
Yeah, just a minor point. So yeah, as you said, even if those devices, they are approved, in practical use, we see there's a lot of noise artifacts still. So the AI algorithms need to be aware of the possible artifacts so that it's not garbage in, garbage out. You know, it should be able to process and get the useful information from this noise.
Thank you both.
I have a question for you. I was wondering if you could talk through kind of how you incorporate consumer sleep technology generated data when a patient brings it to you in clinic. I was wondering if you would be able to share some insight about that.
So, and Dr. Shelgar, I work in the pediatric population. So thankfully, I know the adults get inundated way more than I do. But yes, so I see some benefits. So for instance, although the PAP downloads and that isn't part of the commercial consumer sleep technology, but I think a lot of my patients have started downloading those apps, which has a patient interface. And I feel like they've started, it has increased patient engagement. And they get that real-time feedback. How did my PAP work last night? So that's been helpful for me. I feel like that's increased PAP compliance. In terms of tracking devices, now with kids, again, they don't necessarily always come to me and say, okay, my oxygen levels were low. I've seen mostly pulse ox or oxygen levels being monitored more. And with that, again, photoplethysmography is usually the principle that's being used. And that can vary by so many things. It can vary based on what light is being given. It can vary by even your skin color. So just keeping that in mind, I take it with a grain of salt. And I would usually do an overnight oximetry and then confirm that what the data they are showing us is real or not. But it's a place to start.
Great, thank you.
Thank you for the great talk. I just have a question about the automated PSG scoring. I think that's really interesting on the AI-driven agreement, you know, being near 85%. Is this in regular clinical use, or is it in research right now, or when do you think it may be available for AI-driven scoring?
So I know in adults, there are a few commercially available algorithms. Now, some of them use machine learning where they are giving you specific tools. They are saying that, okay, it has to be sleep spindle, 12 to 16 hertz, passing waning. It defines it for you, right? The way Dr. Sun explained. And some of it utilizes deep learning. I think there was 1 or 2 systems which do utilize deep learning and is commercially available. Those are like your human brain. So they are learning on the go. So to my knowledge, I think FDA has approved use for some of these. And I believe some of the labs, again, I know a lot of them do home sleep studies, testing. I know a few companies who are still doing it. But if I had to guess, I would say like maybe 5 to 10% of the labs maybe are still using it, but it's not mainstream. Dr. Sun, do you have anything to add?
Yeah, it's not mainstream yet. I think the main obstacle is that people worry about the accuracy. You know, of course, it provides you a hypnogram, and you still need to manually look over it again. Then some people think, why bother do it? Why not just go from the start? So that's actually, I think there's a few, well, many studies now start to look at the error produced by these AI methods. And so one way to address this is to improve the interpretability of the model. So if there's some commercial system that can tell you for each epoch how the decision, how the sleep stages is made according to those inputs, I personally think that would be a great way to deal with those errors. Yeah. So they are still in development. Yeah.
And then on that note, at ASM, we are working on a certification program where as each company comes up with its own algorithm and then they are testing it on their own population, we knew there was a need for all those algorithms to be validated or to be reviewed by a central body and with a generalizable testing data set. So at ASM, that's what we are working on, so that if any company has such a data or such an algorithm, they can send it to us and we can analyze that data and then make sure that it meets our standards.
So I wanted to ask, most clinicians don't have a background in computer science or artificial intelligence. So what is the role of the clinicians in helping this technology get to clinical applications?
I think there's a huge role. When you go to YouTube, you will always see they will send you small little feelers where they'll say that, oh, did this video meet your requirement? Or if you're looking at Facebook, it'll ask you these questions. This is how their models are being trained. As clinicians, I think first and foremost, the biggest challenge these data sets is that these data sets have a lot of noises or have a lot of inaccuracy. So again, trying to figure out a way where we can clean this data, I think that's something which I think each of us can do at our level. And then going forward, I think collaborating, if you are interested in utilizing AI and doing research in that, I think collaborating with other scientists or researchers who are working all over the country on this, that may be another step where you're giving them those data sets for them to train the machines on. If you are, and Kishan, are you interested in AI or?
Yeah, I think it's something. I don't have any personal experience or technical experience, but it's like an interesting concept, and obviously would be a good time saver for if it can be made to work.
Yeah, so I think at this level again, or Dr. Sun may have more to add. I'll pause for him.
Yeah. So maybe from my side, it's a different angle because I'm a researcher, so I'm on the other side of clinicians. But I agree with Dr. Pandopade that providing clean data sets to AI researchers, that's for sure a very important way to increase the efficiency. And on top of that, I think, well, by the way, this is a very good question. So on top of that, I think the key is effective communication between clinicians and AI researchers, because these two groups, they obviously speak different languages. So you need a way to, to able to translate what the clinician says into, for example, what's the input of this model, what's the output of this model, so that clinicians usually they have a big vision in their mind, but sometimes they tell you in a story, and you have to within the story pick out what's the input, what's the output. So that's, I would say, the effective communication between clinicians and AI researchers. That's really important. And to achieve that, clinicians, they need to have some basic understanding of AI, such as listening to our webinar here. And for AI researchers, we need to have more, clinical knowledge to be able to communicate with them. So I would say, yes, work closely and communicate and learn from each other. That's a very important thing. Yeah.
That's well said, Dr. Sam. And sometimes we think AI is this magical thing, and then we are just going to like put all the information there, and magically it's going to like start working like me. But I mean, it's only after we've gone over all these concepts that we see where can it go wrong in so many places. Like think of the neural network model. Think of all those different nodes, think of all those like different corrections that you have to make. So in order to train that level of granular detail, I think a clinician is the one who can get that, who can at least say that, oh, no, this doesn't look right. No, this is not. And that's where we need to collaborate.
What about the role of, once this technology is, I guess, more mature, using AI to better define sleep like respiratory events or sleep events, because like you said, there's a lot of subjectivity right now in the way that events are scored, and it's sometimes it seems kind of arbitrary sometimes, or maybe there's reasons that are not perfectly clear, but maybe AI is something that can help to more clearly define the parameters we use to score sleep studies.
Go ahead.
Yeah, exactly. I mean, of course, when you use a machine learning or AI algorithm, the inter-model agreement would be 100%. So that would be that subjectivity is obviously solved. But then for this model to accurately reflect not a single expert's opinion, but a consensus of all the experts' opinion, you need a very well designed data set where the annotations are analyzed, one by one, and you are very confident about all the annotations in the data set. So in this way, once you provide a very high quality data set, then the AI algorithms can learn it and sort of remember it or replace it, and then you can apply this trained model to new recordings. Yeah, that's just from my practical point of view. Yeah.
You've hit the nail on the head, Kishan. So AHI is imperfect, right? There is lots of talks about like how is the AHI helping in diagnosing sleep apnea? Is that the perfect measure? And I think researchers have been trying to figure that out for the last few years. And as a clinician, the way I see, and as I learn, and again, I'm still barely scratching the surface of AI, but as I learn more, I keep thinking that this is, at the end of the day, just a tool. I don't think it can replace my clinical judgment. For instance, when a patient comes into your clinic, has excessive daytime sleepiness, has had all these symptoms, and you see that, yes, there is some functional impairment, you put that in context, and then you diagnose your patient. You look at the comorbidities, heart failure, you have CPD, something else going on. So you have to put all of that in context. So for a machine to do that complex task, and each patient is different. So for a machine to do that for my hundreds of patients, I think that's going to take maybe a while before science can get there. I'm sure it can, but I don't know if it's going to be anytime soon. So then instead, if I just use AI then as a tool, I can't go over this 8 hour of physiologic data. Can it just tell me what the vasomotor symptoms have been all through the night? Like when they are fast breathing, then is there like drop in blood pressure, rise in heart rate? What is that? Maybe that's one. I mean, this is an example, but maybe that's what I want to look at, and I can't do it. So I'll have the machine do it, but I will use that data, which is definitely a little step up from what we now see. And I will use that data to make my clinical judgment. So I see AI being used in that role.
Thank you
approaching,
again.
Go on.
I was just thanking them for a great talk. Thank you.
Yes, we're approaching 11 o'clock. Thank you so much, Dr. Bandyopadhyay and Dr. Sun, for a wonderful lecture on AI. It was very interesting. And thanks to everyone who attended and participated in the polls. As it was mentioned earlier, the recording will be posted on the AASM website in a few weeks if you'd like to listen to it again. Thank you so much for attending today.
Thank you so much for this opportunity.
Yeah.
Yeah. And feel
Thanks
free to
a
reach
lot.
out to us. Yeah. We love talking about AI. Feel free to reach out to us.
Thank you.
Bye.